very good evening to all of you. Welcome all the delegates to the 10th National Update on Diabetes, that is NUCD. And today for this interview, we have Professor Sanjay Bhadada. And as you know, that diabetes affects multiple parts of the body, retina, kidney, vasculature, heart, everything, almost all the parts of the body are affected by diabetes. But diabetes also affects bone. And we do understand that if in elderly person, in old age, the two things are important. Rather I always say two B's are important. That is, one is brain and another is bone. So if your brain is working and your bone is working, then the rest of the things you can keep aside. So yesterday we discussed about the effect of diabetes on brain, and today we'll have a very interesting session on effect of diabetes on bone. And to speak on that, we have Professor Sanjay Kumar Bhadada is there. He is professor and head of the Department of Endocrinology in PGI Chandigarh. He is also past president of Endocrine Society of India. And all the delegates is very much well versed with Professor Bhadada. So without wasting time, I would ask him, Professor Bhadada, what is the relationship of diabetes with bone?
Yeah, so very good afternoon. Thank you, Dr. Kanwar, for a very important question indeed. Till now, we are telling the triopathy, retinopathy, neuropathy, nephropathy is there, but I think this is a high time to speak about the diabetic tetropathy. And the bone involvement in diabetes is like another microvascular complication. And indeed, the bone involvement qualifies for the microvascular complication. So it is a very important close relationship between diabetes and bone. Then there are multiple reasons because of that hyperglycemia or the hyperglycemic load actually harms the bone by multiple mechanisms.
As you mentioned that this is a tetropathy, the various terms has been used: diabetic arthropathy, diabetoporosity, diabetoporosis. So multiple terms being used and being coined to effect of diabetes on bone. Professor Bhadada, what percentage of diabetic people are having involvement of bone?
Yeah, so it is difficult exactly to say that what percentage of patients of type 2 diabetes or type 1 diabetes are affected by the bone, but you can say there is significant percentage, and depends on that what is the duration of diabetes, what is type of diabetes, how was the hyperglycemia over a period of time, what are other associated comorbidities. So if we consider all these factors, those are associated, then the prevalence may be go as high as 30 to 40% patients of type 2 diabetes may be having the some or other bone issue, and maybe severe osteoporosis. From one of our study, which is a hospital-based study, in just 253 patients of type 2 diabetes, we excluded secondary causes, and what we found is that approximately 30% of individuals are having osteoporosis, and it was more severe, more common in the females as compared to the males.
Correct. As we are discussing about the prevalence of diabetes, I suppose you would agree with me that the prevalence varies from type 1 diabetes to type 2 diabetes. Can you just enlighten us how these two types of diabetes being affected by diabetes? Are they pathogenesis or the manifestation or the architecture or BMD? What's your comment on the affection of type 1 and type 2 diabetes on bone?
Yeah. So first, before answering this question, type 1 and type 2 diabetes, our audience might be thinking, if I'll say that type 1 diabetes is more severely affects the bone, and we have multiple reasons. First of all, the hyperglycemic load is very high. The second is peak bone mass is not achieved in type 1 diabetes because of the chronic disease. Third, type 1 diabetes, approximately 10% of individuals of type 1 diabetes are associated with celiac disease. So, and the low IGF-1, actually, these are the multiple factors responsible for the poor bone health in type 1 diabetes. But you might be wondering that in your clinical practice, you don't see many type 1 diabetes patients with the bone issues. The reason is that because mean survival of type 1 diabetes in Indian setting is actually very low. At PGI Chandigarh, if I'll talk, the mean survival in type 1 diabetes is approximately 35 years. So that is not a usual age to develop the osteoporosis actually. So in our clinical practice, we don't see many patients of type 1 diabetes with the osteoporosis, but in type 2 diabetes, the situation is really very, very grim because type 2 diabetes in India is having the central obesity, and central obesity is an important marker of inflammation. And then onset of diabetes in India is relatively early as compared to our Western counterpart. And because of that, the peak bone mass is not achieved actually. On the top of that, in the females, the menopause age is early in Indian patients as compared to the Western population. So low peak bone mass, high inflammatory level, early menopause, and associated vitamin D deficiency actually contributes significantly for the osteoporosis in type 2 diabetes.
What's your comment on the risk factors like the microvascular complications of diabetes, whether they also affect the bone or only the duration or glycemic control are more important?
Yeah, so you are exactly, I agree with your this statement that microvascular complications are significantly affecting the bone because the vasculature is same all over the body. And if I call microvasculature, meaning by that when the capillary thickness is less than 10 micron, it is actually called the microvasculature. So this type of capillary, if affected any other organ, that is similarly affected in the diabetes also. So in case of diabetes, the microvascular complication takes place, then their blood flow is reduced, their adiposity is increased, and the repair process is also impaired because of the involvement of the capillaries. So it is a close association with the other microvascular complications. Further, the microvascular complication actually predisposes for the fall, like retinopathy, CKD, foot involvement, all these also predispose to the fall in patients of type 2 diabetes, and we know fall and fracture has a very, very close association.
So if you look at the BMD, aerial BMD of a type 1 diabetes patient and a type 2 diabetes patient affecting the bone, is there any difference or it's a similar kind of bone mineral density you get?
Yeah, bone mineral density may be even more lower in case of type 1 diabetes because the type 1 diabetes individuals are usually they are short because of multiple mechanisms, and we know that the shorter bone not achieve peak bone mass, so BMD will be lower in type 1 diabetes compared to type 2 diabetes. And on the top of that, the type 1 diabetes individuals are also having microarchitecture alterations because of very early onset of severe hyperglycemia. So very few studies are available at the level of microarchitecture. Microarchitecture is poor in patients of type 1 diabetes as compared to healthy individuals. And our recent data on high resolution peripheral QCT it clearly shown that compared to the healthy individuals, type 1 diabetes individuals are having severe microarchitecture alterations on the HRPQCT.
So, what is the risk of fracture? We know that the type 1 patients having low BMD and type 2 diabetes patients have reasonably higher BMD. What is the risk of fracture in type 1 diabetes or fracture?
Dr. Kanwar, it is such an important question, and I want to answer in elaborate manner that number one, any type of diabetes can increase the risk of fracture. If we talk about type 1 versus type 2 diabetes, the risk of any fracture in patients of type 1 diabetes is approximately 5 times more common as compared to healthy individual. We look at the type 2 diabetes, the risk is approximately 1.5 to 2 times compared to the healthy individual. So meaning by that, risk is 7 times higher in type 1 and 2 times higher in the type 2 diabetes. And it is equally applicable for the hip fracture as well as the spine fracture.
Correct. So to assess a diabetic patient for bone health, what are the tools you use so that this patient is having osteopenia or osteoporosis?
Very good. So there is a there is a issue with the use of the various tools to diagnose the osteoporosis in patients of type 2 diabetes or in type 1 diabetes. So right now you can say the gold standard technique is the DEXA scan only. Again I repeat, the gold standard technique is the DEXA scan only. In the DEXA scan, if the T-score is -2, we consider patient is having osteoporosis because we use a correction factor of -0.5 for type 2 diabetes as compared to healthy individual, right? So DEXA is gold standard, but DEXA is a problem because DEXA does not give information of the cortical porosity. So to get the information of cortical porosity, you may require better facilities to assess the bone health. So people do use the high resolution peripheral QCT, and which is recently approved to assess the bone health in patients of the diabetes. Earlier it was used mainly for the research purpose, but now it is approved by some of the societies that HRP QCT can be used. QCT also can be used, but DEXA is the gold standard.
What is your comment on trabecular bone score? Because you are yes.
Trabecular bone score has a certain limitations, though there is some of the studies are done on the trabecular bone score, but right now on the basis of trabecular bone score, treatment is not yet planned or not indicated on the basis of TBS. But in addition, beyond that, if you can use VFA, that is a very good technique, and that is done on the DEXA scanner itself, and that will give you the vertebral fracture severity and the grade. Means where is the fracture and what is the grade of fracture. So VFA is very useful. TBS is not that useful and currently not used for the treatment on the basis of the TBS report.
In any patient, diabetic or non-diabetic?
Yes, any patient, right.
And what is your comment on FRAC score for prediction of risk in diabetic patient?
Right. So FRAC score is used widely, and though the diabetes is some of the places it is mentioned, but otherwise they use as a secondary cause of osteoporosis. They tick that instead of mentioning the patient is having diabetes, and they calculate the FRAC risk by that. So diabetes is considered secondary cause of osteoporosis, and that can be FRAC can be used for the prediction of the fracture. And on that basis, when we are in the dilemma and the patient is already having, say, kind of T-score -2 and the FRAC score is high, then we start the treatment in these patients with the help of FRACs.
Yes, I absolutely do agree with you. Even with the lower FRAC score as compared to non-diabetic, diabetics are higher risk of having a fracture in the future. There has been various modification to the FRAC score, like the increasing age or replacing rheumatoid arthritis at the point with the diabetes. So what's your comment on those modification of FRAC score in the diabetic population? How far is acceptable and correct?
Yeah. So I think this is a good idea because we all know that diabetes is a disease which is affecting each and every compartment of the bone, whether it is a mineral component, whether it is the matrix component, whether it is a marrow component, and currently available facilities to diagnose diabetes associated osteoporosis is not that robust. So FRAX is a good idea and that can be used or utilized to calculate the risk. And I'll tell you, like, for example, you want to treat the pre-diabetes, right? Now the people are treating pre-diabetes. Why don't you want to treat the pre-osteoporosis or osteopenia? I can argue with that. So
Yes.
when the diabetes patients are already at the risk, and because it is a multifactorial, then it is nice to use these facilities till we have the better modalities to say predict fracture in the patients of type 2 diabetes with the imaging.
Okay. Now, after the diagnosing osteoporosis or low bone mass in diabetes, we move to another important clinical aspect regarding anti-diabetic therapy. There are multiple anti-diabetic therapy which increases the fracture risk, and some of the anti-diabetic for good for bone health. So, can you please elaborate on those anti-diabetic therapy?
Some of the anti-diabetic drugs should be avoided, like pioglitazone or the thiazolidine should be avoided because there is a data available with the thiazolidine that can increase the risk of fracture, especially the long bone fractures. So pioglitazone should be avoided. The message to the audience is that any patient, you should ask for history of fracture in diabetes. Now that is an important part of history taking. If there is a fracture, don't use thiazolidine. Second, if the patient is having strong family history of fracture or any other risk factor for the metabolic bone disease, then we should avoid glitazones or thiazolidine. Regarding the gliflozins, there is some study that increases the risk of bone health, but more and more studies are coming and there is no significant effect of gliflozins on the bone health. We did recent one study where you used the standard therapy plus dapagliflozin, and we did all the DEXA scan, HRPQ-CT. At the end of follow-up 1 year, in none of the patient with dapagliflozin group is having poor bone health as compared to the standard therapy. So it seems gliflozins are the safer drugs, like any other oral antidiabetes. Metformin is good one, obviously that is safe. And insulin, they say that insulin increases the risk of fall somehow because of hypoglycemia. But anyway, as and when required, we have to give that. So in nutshell, I say avoid these thiazolidine. Rest are either neutral or okay. DPP-4 inhibitors are good choice, and the GLP-1 analogs are found to be useful because they stimulate the osteoblast.
Okay. It's a fantastic response and a very practical points in treating diabetes with osteoporosis. And the just last point, we are coming to end of our discussion. If a diabetes patient with osteoporosis or T-score -2, then what anti-resorptive or anabolic agent you would like to treat these patients?
Dr. Kavam, I am very, very happy to interact with you, and you ask very, very pertinent and relevant, very practical questions. And indeed, to answer this question, we planned a study 3 years back, where what we did is we have selected the patients of type 2 diabetes with osteoporosis and one control group. And one group was given teriparatide, that is recombinant human PTH. Other group was given zoledronate, and the third group was given the denosumab, that is rank ligand antibody. And what we found at the end of 52 weeks of the follow-up with this three treatment modalities, the teriparatide fared better to increase the bone mineral density at lumbar spine compared to zoledronate and denosumab. But over a 1 year period of follow-up, there was no significant difference in the fall, fracture, or the BMD at the measured at the tibia and the radius. There was no significant difference. except there is bone mineral density was increased with teriparatide at the lumbar spine, and which is expected because that is true for the non-diabetic individuals also. So as of now, I can say that any drug can be used. They are almost having equal efficacy, but in our setting, maybe Jolidinot is a good choice because it is easily available, once a year therapy, and cost effective as well. So I can say at this point of time, the Jolidinot is can be a good choice. But if the lumbar spine is the problem, use teriparatide. If the hip is the problem, use Jolidinot. If problem at the both side, you can use the denosumab like in any other non-diabetic patient with osteoporosis.
Excellent, excellent. Thank you, Professor Bhadada. We heard directly from horse's mouth, who really works in the field of bone and diabetes, effect of diabetes on bone. He has lots of work on that. So it was a very informative session. He elaborately discussed about the pathogenesis of bone involvement in diabetes and how to diagnose and what drugs to use, what anti-diabetic drugs to avoid, and how to treat osteoporosis in a patient with diabetes. Thank you, Professor Bhadada. Thank you for your for enlightening us. Thank you.
Thank you, Dr. Kumar, for this nice introduction and opportunity. Thank you. Namaskar.
Thank you, sir.